Welcome to the deep dive. Today we're tackling one of the body's true multitasking marvels, the pancreas.
hmm
This is a flattened retroperitoneal organ,
hmm
which means it's tucked way back, behind the main abdominal cavity. It's just an absolute
It
powerhouse.
really is. It does so much, from bulk digestion with its exocrine output to fine-tuning your blood sugar with its hormones.
So our mission today is pretty simple, but, also a little challenging. We want to build you a detailed, high-resolution map of this gland.
Right.
We want you to be able to visualize every crucial relationship, the vessels it drapes over, the ducts it shares, all the structures that really dictate its pathology. This isn't just a list.
No, the goal is to understand why the anatomy makes pancreatic disease
Yeah.
so difficult to manage.
Exactly. So where should we start? Maybe just the physical look and feel of it?
Yeah, let's do that. So a healthy pancreas is typically yellow, it's soft to firm, and it has this visibly lobulated sort of bumpy surface. But here's an immediate clinical connection. Surgeons have actually observed that the consistency of the gland post-op is, it's a prognostic factor.
What do you mean?
The harder the tissue feels during the operation, the lower the rate of pancreatic fluid leakage after a major surgery.
Wait, really? So the physical density is literally a prognosis factor?
It is, yeah.
That's incredible. The consistency translates directly to recovery risk.
Precisely. It's a very tangible signpost for the team.
Okay, so let's talk scale and position. If you're trying to visualize it at home, what should you picture?
Think of a flattened, sort of elongated organ, maybe 12 to 15 centimeters long.
Like a flattened tongue, almost.
Exactly. And it's draped transversely across the back wall of the abdomen, the retroperitoneum lying just behind the stomach. It stretches all the way from the C curve of the duodenum on the right across to the spleen on the left.
It takes up a lot of hidden space, then.
It does. Its volume is about 70 to 80 cubic centimeters in adults. It usually peaks in size around your 40s, and then it starts to shrink a bit after age 60.
And what's holding it in place back there? You mentioned it's posterior.
Right. So its front surface is covered by parietal peritoneum, but its backside rests on these really crucial layers of loose connective tissue.
Okay.
Surgically, we call them the fusion fascia of Treitz, which supports the head, and the fusion fascia of Tolt for the body and tail.
And these aren't just padding, I assume.
Not at all. They represent natural dissection planes. They're like anatomical guides that surgeons use to separate the pancreas from the huge vessels underneath.
Got it. Okay, let's unpack this region by region. Let's start on the right with the thickest part, the head and its little extension, the uncinate process.
The head is perfectly nested, just filling that C curve or the duodenum, and its relationships to the big vessels are just critical.
How so?
If you look behind it, the head lies directly anterior to the inferior vena cava, the IVC.
That massive low-pressure vein.
Exactly. So a tumor there immediately threatens that vessel.
And then there's its famous partnership with the biliary system.
Absolutely. The common bile duct is partially embedded right into the back of the head just before it enters the duodenum.
Which explains so much.
It's the anatomical reason why a tumor in the head of the pancreas causes that early bile duct obstruction. It's why patients often present with jaundice.
Okay, that brings us to the uncinate process. This hook-shaped bit that comes off the head, it sounds like it's weaving through some high-traffic areas.
It is a critical path. Picture it extending medially, hooking like a finger. It passes in front of the abdominal aorta, the main highway, and above the horizontal part of the duodenum.
Wow.
So when cancer grows there, that specific interwoven path means it can quickly encase the major mesenteric vessels, and that's often a death sentence for being able to do surgery.
That visualization helps a lot. Okay, moving left, we hit the neck. People call it the surgical junction. It's narrow, right?
Yeah, only about 2 centimeters wide, and it tends to be the most anterior or frontmost part of the whole gland.
And this is where we really need to slow down, you said.
Yes. The neck's anatomy is arguably the most critical part for staging cancer. The neck is the part of the gland lying right in front of the confluence, the meeting point of the superior mesenteric vein and the splenic vein.
And when those two merge.
They create the hepatic portal vein.
So for a surgeon evaluating a tumor, why is this specific spot so important? What are the implications?
Because if the cancer wraps around or invades that portal vein complex, we call it venous encasement, it pushes the disease into a much more advanced category, often borderline resectable.
So the entire decision to operate can hinge on what's happening right there at the neck.
It very often does.
Okay, past the neck, we get into the body. It's the longest section.
Right, and it gets progressively thinner with a kind of triangular shape in cross-section.
And its neighbors, what's in front and what's behind it.
Anteriorly, it's covered by peritoneum. But superiorly, there's a key separation. The stomach is separated from the pancreas body by the empty space of the omental bursa. Think of it as a thin cushion.
And posteriorly.
Posteriorly, the body is truly draped across the retroperitoneum. It's resting on that fascia of Tolt we mentioned, and it's lying over the aorta, the left crus of the diaphragm, the left suprarenal gland, and the top of the left kidney.
That is a lot of important real estate right underneath it.
It is, and probably the most prominent feature on its back surface is the splenic vein. It runs directly along it.
So it's right on top of the pancreas.
In many people, it actually creates a really deep groove, or sometimes even a tunnel, right in the pancreatic tissue itself.
Wow. Okay, and finally, we reach the tail. The narrowest part, way over on the left.
Just a few centimeters long. It terminates right near the spleen. And because of its position, it lies between the splenorenal ligament and the splenic hilum.
And that location puts it at risk during surgery, right?
A huge risk, especially during a splenectomy. When surgeons are trying to tie off the splenic vessels, that tail is right there. You have to identify it and protect it rigorously.
All right, let's move inside to the plumbing system. The pancreatic ducts. Let's start with the main one, the duct of Wirsung.
Okay, so it runs a bit diagonally from the tail toward the head, and the way it collects fluid is really specific.
How so?
The smaller ducts from the lobules join the main duct almost at right angles. It creates this pattern that anatomists call a herringbone pattern.
Ah, I can picture that. And the duct itself isn't a fixed size, I understand.
That's right. Its diameter gets bigger as it goes. It might start at 1 millimeter in the tail, but it expands to 3 millimeters in the head. And importantly, it keeps thickening after the 5th decade of life.
Which is something you'd have to keep in mind when looking at an imaging scan.
Absolutely, so you don't misinterpret it.
And eventually this main duct meets up with the bile duct.
Right. It joins the bile duct, and they enter the duodenum together at the major duodenal papilla. Sometimes they form a little common channel, the ampulla of Voter.
And the length of that channel matters.
It does. It's usually short, maybe 5 to 7 millimeters. But an abnormally long one is a clinical concern because it allows bile to reflux back into the pancreatic duct.
Which is not good.
No, it's linked to an increased risk of biliary tract cancer.
Then we have the smaller one, the accessory duct, or duct of Santorini.
Right. This one drains the upper front part of the head and usually opens onto the minor duodenal papilla, which is about 2 centimeters higher up than the major one.
And this whole duct system brings us to a really important clinical variation. Pancreas divisum. What's happening there?
This affects about 5 to 10% of people. It's basically a failure of the duct system to fuse properly during development.
And functionally, what does that mean?
It means that the majority of the pancreas ends up draining through that tiny accessory duct and the minor papilla instead of the big main one.
That sounds like a drainage nightmare. Like you said, a garden hose volume through a drinking straw.
That's a perfect analogy. And for people who are susceptible, this anatomical bottleneck is what leads directly to recurrent episodes of acute pancreatitis. The backup causes the damage.
Okay, let's trace the vascular highway. The pancreas must need an incredible blood supply.
It does. It's a factory. And the supply is unique because it comes from 2 major sources: the coeliac trunk and the superior mesenteric artery, the SMA.
A built-in redundancy.
Exactly. And it's essential.
So walk us through the supply to the head and the duodenum with those famous arcades.
Right. So this region gets blood from 4 key arteries. You have the anterior and posterior superior pancreaticoduodenal arteries from the gastroduodenal,
Okay.
and then the anterior and posterior inferior pancreaticoduodenal arteries from the SMA.
And they all connect.
They all connect. They form the anterior and posterior pancreaticoduodenal arcades. It's this vital overlapping network ensuring that the duodenum and the head of the pancreas are supplied together.
What about the rest of it, the body and tail?
That's primarily supplied by the splenic artery, which is famously tortuous or twisty. It runs along the top border of the pancreas and gives off branches all along the way.
It sounds like the top and bottom borders of the gland are just laced with tiny arteries. Does that create problems during surgery?
It absolutely does. When a surgeon has to transect a gland, they have to meticulously ligate all those small arteries running along the borders to prevent major bleeding. It's just incredibly vascular tissue.
Now, for venous drainage, does the blood just follow the arteries back?
Pretty much, yeah. It drains into the hepatic portal, superior mesenteric, and splenic veins. It really reinforces that critical confluence point at the neck we talked about.
Are there any specific drainage points that are surgically tricky?
Oh, yes. The inferior pancreaticoduodenal veins drain right into the back of the superior mesenteric vein, underneath the unsplenionate process.
Right in that hook.
Exactly. And that spot is a major site of potential hemorrhage during a Whipple procedure. It's a well-known high-risk area.
And we should probably mention the connection to the systemic veins, the veins of Retzius.
Right. In patients with portal hypertension, so high pressure in that portal system, these little communications can swell up and form varices deep in the retroperitoneum.
And finally, on this vascular tour, the lymphatic drainage. This network is tied to the poor prognosis of pancreatic cancer, isn't it?
It is. The lymphatics follow the arteries very closely, and they all funnel centrally into the preaortic nodes between the coeliac trunk and the SMA.
Which is a terrible place for cancer to drain to.
It's the worst. It facilitates early and widespread metastatic spread.
Okay, let's zoom in to the microscopic level. Let's talk control and microstructure, starting with the nerves.
The parasympathetic input, which comes from the vagus nerve, basically tells the gland to go.
Yeah.
It modulates secretion. The sympathetic input from the T6 to T12 spinal levels is more of a stop signal, causing vasoconstriction and inhibiting secretions.
But the nerves are also responsible for that horrible pain that comes with pancreatic disease. Where is that coming from?
Right, the sensory information travels back to the spinal cord from about T5 to T9. But critically, we know there are two very dense nerve bundles, plexus the first and plexus the second, located right in the head and neck region.
And this is key for cancer pain.
Absolutely. Cancer cells in pancreatic tumors love to invade these nerves. We call it perineural invasion. This aggressive infiltration along those nerve plexuses is the main anatomical reason for the agonizing pain patients feel.
And because it's so deep and retroperitoneal, the pain is often referred.
Yeah, exactly.
Yeah.
It's poorly localized. The inflammation or cancer quickly involves all the adjacent
Right.
tissues, so patients often describe it as a chronic low back pain, and that can tragically delay the diagnosis.
Now, for the microstructure, 98% of the pancreas is exocrine. It's the enzyme factory.
Right, you have these acini, made of pyramid-shaped cells that secrete digestive enzymes. That's controlled by the hormone CCK. Then you have the duct cells that release bicarbonate and water to neutralize stomach acid, and that's controlled by secretin.
And there's another cell we need to mention, the pancreatic stellate cell.
Yes, these are quiet but destructive. They were the key drivers of fibrosis and chronic pancreatitis, and they also create the dense protective shell around pancreatic tumors.
The final 2% is endocrine, the islets of Langerhans.
Right, these highly vascularized clusters. You've got beta cells making insulin, alpha cells making glucagon, delta cells making somatostatin, and F cells making pancreatic polypeptide.
And there's a key difference in humans.
There is. A quick note for our listeners. Human islets show a uniform distribution of these cells. This is very different from the core mantle structure you might read about in, say, mouse models.
Good to know. Okay, finally, let's tie all of this anatomy together with clinical correlations. The deep fixed location explains a lot about acute pancreatitis symptoms.
It does. When the gland gets inflamed, enzymes start auto-digesting the tissues around it. This leads to that classic retroperitoneal hemorrhage and the signs we look for.
Cullen sign and Gray Turner sign.
Exactly. Cullen sign is bruising around the belly button, and Gray Turner sign is bruising along the flanks. It's the blood tracking through those retroperitoneal planes.
And what about pancreatic pseudocysts anatomically?
They are fluid collections that build up in front of the pancreas in that omental bursa space. They're called pseudo because they don't have a true epithelial lining like a real cyst would.
In terms of pancreatic tumors, we know most are in the head. And we talked about how that causes jaundice.
Right, and on an imaging scan, this shows up as the classic double duct sign. You see both the common bile duct and the main pancreatic duct are dilated. It's a huge red flag for a tumor in the head.
Which brings us to the Whipple procedure. Why do surgeons have to take out the duodenum along with the pancreatic head?
It all comes back to those pancreaticoduodenal arcades we talked about. The blood supply is so tightly interwoven that you simply cannot remove the head of the pancreas safely without also taking the duodenum it's attached to.
There's no way to separate them.
No, they are a single vascular unit.
And there's one last surgical risk, a vascular variation surgeons have to watch for.
This is critical. They must look for and preserve an accessory or replaced right hepatic artery. It's a common variation where this artery runs right across the back of the pancreatic head.
And if you cut it,
If you inadvertently ligate it, you can compromise the entire arterial supply to the right lobe of the liver. It's a catastrophic complication.
what a detailed and frankly dangerous neighborhood this gland lives in. We've mapped the 4 regions, traced those critical arcades for the Whipple, navigated the portal vein confluence at the neck, and connected the microstructure directly to pain and disease.
And as we close this deep dive, just take a moment to consider the cumulative effect of that confined space.
Yeah.
We talked about the incredible concentration of nerves, plexus and 2, and that extensive lymphatic drainage, all packed into the retroperitoneum.
Yeah.
So think about that fixed, rigid location again. How does that anatomical confinement amplify the severity of symptoms and the speed of spread compared to an organ that's just, freely suspended in the abdomen?
It gives it nowhere to go.
Nowhere to go. That rigid boundary means inflammation, or a tumor has no choice but to push against everything around it, causing pain and involving major vessels incredibly quickly.
That structural reality, it really does explain the clinical severity. Thank you for joining us on this deep dive.
My pleasure.
Keep learning, and we'll see you next time.